to another issue that I think comes up a lot for people. And that's the question of, what do you do when you're looking for a particular type of treatment and you can't find anybody in network? This happens a lot in the mental health field, but I'm seeing more and more cases in the medical side where networks won't have, for example, a qualified surgeon to do a particular type of surgery, or a specialist in something, and people, get frustrated. So let me just go over. We talked last time about the different types of policies, the PPOs, the HMOs, the EPOs. But one thing that is the same across the board is, regardless of the type of coverage you have, if your insurance company does not have someone in network who's qualified to treat, they are required to pay an out-of-network provider as if he or she is in network. Now, having said that, the path to getting there can be very rocky. First of all, I just want to talk about this trend that we're seeing, where a lot of insurance companies have inadequate networks, or what we call ghost networks, where you'll look up, you'll go on your portal and you'll look up, I need a urologist, and there'll be 27 people listed, and then as you start going down the list, this one's retired and that one's not taking any patients, and this one isn't really in network. And it's a huge problem that's going on across the board. So don't be surprised if that happens to you. And again, you have to stay on it, because it's you need to exercise a lot of diligence to work through it. So the first step, of course, is to look in network. Now, how do you do that? I always suggest that you're always on your insurance company's portal so you can access what they have online. I would also suggest that you always call. Every insurance company will say, our portal, our list is constantly changing. We don't guarantee that this is the most updated list, which is very frustrating. But if you're trying to see if you can find someone in network, I think you need to do both things. Print out what's online and call and ask for a list and tell them what you're looking for. And then the real work begins, because you're going to start calling and saying, this is what I need. Will you treat me? And take meticulous notes when everybody says no. No, I'm not really in network. No, I won't. I'm not taking new patients. No, I don't treat that condition. And so you're going to have to sort of work through the list. Okay, so then what do you do if you can't find anybody? The next thing that I would suggest is that you find the person you want. Now you've exhausted the network. Now find the person you really want to treat with. And make sure that person is willing to treat you. Make sure that they're qualified to treat you. And the first step usually is to just ask for a consultation or an appointment, especially if what you're looking for is something long-term or really expensive, like a surgery or a long-term treatment. The reason I say to do it that way is because I have found that if you ask for the consultation, a lot of times you'll get it even as an in-network consultation. Or a lot of times when you end up having to go through litigation, the fact that you ask for the consultation first helps your case. So, for example, I'm dealing with a case right now that had to do with a particular surgery, a very difficult surgery. And so we walked the client through just asking, can I go see this other surgeon because I'm not satisfied with your in-network surgeries? And the insurance company said no. And so we advised that she pay for this out of pocket. Now, some of these can be $600 to $1,000 for one consultation, which is a lot of money. But by doing that, you then get the opinion of the out-of-network doctor that's going to help you ultimately get the coverage you need. For example, in this case I'm handling, the out-of-network surgeon does the particular surgery she needed 2-3 times a week. I mean, he's got a whole team in there doing it all the time, as compared to the in-network surgeon who had never seen this surgery before, had seen similar ones, but not this particular one. So she was able to gather that information, and we were able to present that to the insurance company. The other part of this, I always say to people, you have to, of course, put your health first. What you need for your treatment has to come first. I talk to a lot of parents of children with mental health issues, and specifically eating disorder issues. And one of the first things I always say to them, which they're shocked at, is gather your resources. If you have a savings account, if you have a credit card, if you have family who can help, because I hardly ever seen anyone who goes through a major mental health treatment without having to lay out at least some money, and usually a significant amount, even if at the end of the day they get it back. And you have to think first about what does my child need, or what do I need? Then how am I going to get that money back that I laid out that I shouldn't have had to lay out? And so doing this process of going to the out-of-network and even having the surgery or having the treatment and then pursuing it is pretty typical, unfortunately. Now, of course, lots of people can't do that. And we can try to intervene in court at that point and try to get the surgery approved, or get the insurance company, get an injunction or something from the court. But what we will need to do that is somebody who's done this process that I'm talking about. So you ask for the consultation, they either agree or they don't. You pay for the consultation, you gather the information you need to show that this out-of-network provider is qualified as compared to the in-network provider. And then you ask for the surgery or the treatment to be approved. And so that's a second step. Now, I can't promise that it's going to be approved, but the whole point is that you've got kind of gathered and built up your record of why you're doing this. And then probably the hardest part is, well, if they approve, what does that mean? Because an out-of-network provider, being out of network means they don't want to have a contract with your insurance company. They don't want to agree to what they're going to pay. And so now if you've demonstrated, well, you don't have anybody in network, and your insurance company says to your provider, okay, we have to pay you, then the negotiation begins between the two of them. And as a patient, you're not part of it. As a lawyer, I'm not part of it. But that can become really difficult. Now, your position as the patient and my position as the attorney is, I don't care, insurance company, if it's difficult. You got to make it happen because I need this treatment. But it's not an easy thing to get accomplished. I spent a lot of time in my career advising providers. I don't represent providers usually, but if a provider asks me, I usually tell them not to be in network because the reimbursement rate is so low, and that's what you're up against. So, and if you ever looked at an EOB or a bill, you can see, the hospital charges $60,000 and the insurance company pays $5,000. So that's the challenge that you have to face. It seems really daunting, and honestly, often it really is. But the process that I'm describing is something you need to do if you're ever going to potentially recover for a treatment that's out of network that you think should have been part of the network provided by your insurance company. And as I said, the standard is they have to have someone in the network qualified to perform the service. You know, I'm not watching the chat, Julie, so you interrupt me if there's anything in there I need to know about. So
will do. Right now, I'm just typing to everybody, but you know what? It's a great way to pause if you don't mind, Lisa, just to reinforce. We had somebody else just pop on. Lisa's got a plethora of knowledge and will just goes through a wonderful process. And she is not going to be offended if you raise your hand with that reaction or you unmute and say, Lisa, I really don't want you guys to worry. Like I said, we're a smaller crew today. This is a good Q&A session. So with that said, I'm going to mute myself again, Lisa.
Okay, sounds good. So any questions about that? I know I had another point about that. One of the, and we talked a little bit about this last month, one of the frustrating things is that when you do have to go out of network and you're choosing to go out of network, the predictability in what is going to get paid is just not there. And that's part of what the insurance company, how they incentivize you to go in network, because you have more predictability about what's going to get paid, and you can't be balance billed. I hear a lot of arguments from insurance companies, especially when someone comes to me with an HMO, where they say, well, you know, you bought the Ford, you didn't buy the Cadillac, and so this is what you're stuck with. And that is, I want to emphasize that is just not true. You are entitled to a qualified person to treat you. Now, you know, there may be an argument over what does qualified mean. I don't think there should be. But qualified does not mean that they have a medical degree. They have to be qualified to do the particular type of treatment or program or surgery that you need. So keep that in mind. So let me move on, because I can talk forever about health insurance issues. One issue that's come to my attention recently, and I wanted to see maybe if anybody had this happen, was who pays for your deductible or copayment. And in particular, there are a lot of programs out there, I've used them myself, where pharmaceutical companies will give you a coupon. I don't know if your pharmacist has ever said to you, oh, I have a coupon for this prescription. Or if you apply, they may waive the deductible. And some insurance policies are now saying that if you take advantage of that, then you have not met your obligation under the policy. So let's say there was a $500 deductible on a very expensive medication. And the pharmaceutical company said, we're going to waive it, or we're going to waive half of it. Even though it benefits you because you can pay less, you're going to have to pay that $250 or that $500 somewhere else. So you don't really get the benefit of the coupon or the discount that they're giving. There are some nonprofit organizations out there that are trying to get laws passed in different states to ban this from insurance policies. California is not one of them that has that law right now. Arizona is, just for example. but you need to be aware of that and where you are and whether your policy says that they can do that. Hitting deductibles in hitting your out-of-pocket max, which is actually the more important number, it doesn't happen often for a lot of us. But when you have those years where you have a catastrophic event or a large treatment, it becomes really important. And in my view, the promise that your exposure is limited to whatever the out-of-pocket is, whether it's 1,000 or 5,000, that promise is broken when the insurance company doesn't allow for other people helping you. I mean, we hear insurance companies making the distinction between family members and pharmaceutical companies. You know, if I pay for my child's deductible, they think that is okay. But if a pharmaceutical company underwrites that, they think it isn't. And I think that is going to be sort of the next frontier of litigation in the health insurance area. Because a lot of people, especially those organizations representing those with chronic illnesses, are kind of up in arms about this, which I don't blame them about. Has anybody experienced that or had a problem with that? Interesting. Okay. So I'm going to move on and dive into another area that is probably the area of health insurance that most litigation is about, and especially some recent class actions in California, at least, and that's the issue of medical necessity. A medical necessity is a requirement of coverage that's written into every insurance policy. When we all hear as lay people medical necessity, we think it's a medical issue, you know, that has a doctor decided that this is something that should be done. And unfortunately, in insurance lingo, it's not a medical issue as much as it is a coverage issue. So what does that mean? Well, it can be very complicated. So every policy says you are covered for what the standard of care in the industry is. So I like to think about that old Crest commercial. 99 out of 100 dentists, you know, say you should brush your teeth with Crest. If 99 of 100 cardiologists say, you know, you should have a stent instead of medication, then your insurance company should pay for that stent procedure rather than requiring you to start medication. On the medical side, these issues come up, but they come up much more often on the mental health side, as usual. And it often has to do with levels of care. You know, do you need to be in a residential treatment center or a day treatment program? What we're seeing now in the litigation is the policy language itself kind of all says the same thing, you know, standard of care in the community, whatever that is. But what insurance companies do is that they create policies and procedures or guidelines that are outside of the policy language. And you, as a consumer or a patient, you don't get to see those until you have a problem. So if you ask for, you know, a stent placement for a heart, and the insurance company's doctor says this is not the standard of care for your position, they will usually cite to their internal guideline on when a stent is appropriate. And here's where the real fun begins for people like me, because first of all, we have the whole debate as to how can they have these sort of hidden guidelines that you don't get to see until you have a problem. And then all of a sudden they pop up and you have to deal with them. And second of all, we find that a lot of these internal guidelines are outdated. They are not really the current standard of care. And they're created by committees and insurance companies that, you know, are not necessarily treaters, so they don't really know what's going on out there. And so a lot of the litigation and debate starts swirling around these internal guidelines, especially in the mental health field. Now, I'm going to talk a little bit about the eating disorder field because it's near and dear to my heart. We suffer in the eating disorder arena from lack of clarity, even within our treaters, as to what the standards are and how do you determine proper levels of care. We had some old American Psychiatric Association guidelines that were very skeletal that we used for a long time. They were from, I think, 2012. And then the American Psychiatric Association recently came up with a new set of guidelines, but I don't think they're all that helpful, because what insurance companies need is specificity. They need sort of a laundry list. And that's what they create. So as treaters don't invest time and effort in this because they're out there treating, but insurance companies invest time and effort in this, and it becomes overwhelming and very difficult for patients. I don't know if I mentioned this last month, but I once tried a case about residential treatment, and the insurance company representative testified on the stand that in order to get residential treatment, you needed to meet a child with an eating disorder needed to meet 17 different criteria. And if the child had reasonably functional parents, I think that was the phrase. In other words, they were parents who were not accused of abuse, just reasonably functional parents, that disqualified any child from residential treatment, because the concept from that insurance company was, well, the child can be treated at home with just outpatient treatment. Now, that was an extreme, but I can tell you, I see those kinds of extremes a lot. That insurance companies are creating these guidelines and you have to jump through so many hoops. One in particular, I want to make sure you look out for is this concept of failing first. Failing first is a concept that you cannot get to a higher level of care unless you've failed at a lower level of care. And the Federal Mental Health Parity Act clearly states you cannot require that anymore, although a lot of insurance companies will still do that. You may see this also in areas of prescription medication, which I think is a whole other area where some of us lawyers need to be attacking insurance companies, because I don't know. I know I've experienced this when your doctor says, try this medication for this problem, and the insurance company says, well, we want you to try this other medication first. And then if you fail on that medication, we'll give you the one your doctor wants. Why? I think it's because different insurance companies have different agreements with different pharmaceutical companies and they pay less for the medication. That's my suspicious attitude. Or somebody internally has decided one is more effective than the other, and what your doctor says is not that important to them. But this concept of failing first it feeds into the medical necessity issue. So a lot of times you'll see someone with a mental health disorder in particular who has an acute episode and the doctor wants to put that person in a residential treatment center for 24-hour supervision, and the insurance company would say, well, you need to try 3 hours a day first, and then if you fail at that, you can go to 5 hours a day. If you fail at that, you can go to all day, a 24-hour. And we know as lawyers that's not correct. You have to be evaluated. The child has to be evaluated on what is needed, but insurance companies will also have this step process, often have this step process in their guidelines. They're sort of hidden guidelines that you don't see. And I would call them out on that for sure, because that's not something they should be allowed to do.
Hey, Lisa, do you mind?
Go ahead.
Just pop in? I had 2 questions actually.
Okay, I'm having a hard time hearing you. Let me turn my volume up.
Sorry, is this better?
Yeah, go ahead.
Okay. I was wondering if there are any guidelines for the level of care with depression, like the same way you mentioned eating disorders. And then also I was wondering, with your experience with Kaiser, like Kaiser saying no to this, but outside consultations are saying yes, but I can't, like Kaiser's only saying no to me. They're not like writing it down because there's no request.
Yeah.
Have any thoughts on that?
Yeah, I have lots of thoughts on Kaiser. I could talk about Kaiser for days. Well, first of all, as to your first question, yes, there are guidelines on depression as well. A lot of insurance companies are using standard guidelines that are created by third-party companies for all mental health. Kaiser seems to have their own, but there are those guidelines. I think some of them are better than others. I've heard of, there's something called McKesson, and there's other guidelines out there. There's the focus system. But a lot of them have the same defects that I'm talking about, the fail first, or the a lot of times with depression, they will say you have to be a danger to yourself or others to even get residential treatment, and that is not the standard in the community. If you're a danger to yourself or others, you need to be in a locked hospital. That you do not need to be a danger to yourself or others to get residential treatment. But a lot of insurance companies insist on that. So let's talk about Kaiser. Kaiser is an animal all of its own. It has a very unique system for asking for treatment. And in addition to that unique system, it has what I would like to call an artificial distinction between your insurance and your doctors. Because when you walk into a Kaiser system, you think you're at Kaiser, but they have this artificial distinction between the insurance and the doctors. They are notorious for not having a robust network of mental health providers, and for requiring that you fight like hell, usually with a lawyer, to get the appropriate level of care. So I'm not surprised that you're struggling. I'll give you one example. If you say to your doctor, I think I need a higher level of care. I think I need day treatment or residential treatment. Even if your Kaiser doctor agrees, that doesn't mean you're going to get it. The Kaiser insurance has to agree. And I have had testimony from Kaiser doctors, because Kaiser uses a system called a referral system. So the doctor has to ask for a referral to the level of care. And I have had Kaiser doctors tell me that they don't ever bother doing that because Kaiser always says no. Even though as a patient, you need to get that request for you to get that treatment. So it is a very, very screwy system. You mentioned something about outside people or others saying you need it. If you're working with someone outside the Kaiser system, that's great. I am not surprised they disagree with what Kaiser is saying. I'd be happy to look at what you're dealing with to see if I can help you. But to get through the Kaiser system, as I said, you're going to have to get that referral. And if a doctor won't give it to you, you can ask for it yourself. You can send an email in the portal and say, I want a referral to X. I want a referral to this therapist. I want a referral to this program. And they have to respond. Now, chances are they're going to say no, but then we can, escalate it and appeal. The one, I think we talked a little bit last month about the two different regulatory agencies in California. Kaiser is under the Department of Managed Healthcare. They have been pretty responsive recently in correcting Kaiser on these mental health claims. So if I'm happy to help you sort of work through the actual Kaiser system and get up there, because oftentimes you will find you'll get what you need once you get through the whole process. And I know it's infuriating, especially when you're struggling, when you're hurting, to have to do that process is very infuriating. But I'm happy to help you if you want to talk offline or send me an email. I can help you through it.
Thank you. I'll definitely do that.
Okay, great. Now remember too, one of the things is that I said before, ask for the consultation, then ask for the treatment. That might help as well. Because if you get the consultation outside Kaiser and it supports you, that helps you to get the treatment that you need outside of Kaiser.
Hey, Lisa, I have a question that I'd like you to talk about, because I read something recently and you had a comment or two on it. And we're brought up in our society, obviously, to be polite and pleasant. When people say, hi, how are you? We say, fine, how are you? But when we're not fine and we're walking into a doctor's office, how does that impact our medical records when we say I'm fine, when we're really not fine?
Yeah, it is a problem. It's a problem also with people who are looking for disability benefits. But in health also, I've seen an insurance company look at that and say, well, look, she reported on this day that she was fine. So how could she need residential treatment? And so it's really hard. It's hard to change the way you're brought up. But it's so important, especially when you're dealing with a system like Kaiser, that you are very clear with the symptoms you're experiencing, the struggles that you're having, and what you think you need. And you're entitled to say what you think you need. So that's a really good question. And I should remind everybody every month that your job is not to make your provider feel more comfortable by saying, yeah, I'm fine. Your job is to advocate for yourself. One of the things that people don't appreciate, and it is shocking, I think, when you're not in this business, is an insurance company does not have to listen to your doctor. I mean, it sounds really weird, but we have under the law something called the treating physician rule. And in Social Security cases, which we're not really talking about today, treating physicians get their opinions are given more weight because they've actually looked at the patient, been with the patient, observed what's going on. In health insurance claims, it doesn't really work that way. I mean, yes, of course, you always say in court, well, this doctor actually looked at Lisa and saw her in pain and listened to what she had to say. And this other doctor was just reading, cold records, and from those cold records, making this decision. And that argument goes some way, but it's very challenging and frustrating for, those of us who are suffering, because why should somebody who's never met you have any say in what your coverage is? And oftentimes it's somebody who's never treated what you're going through, who a lot of these insurance companies, doctors don't treat at all. They're just reviewers of records, and it's really infuriating. One of the things we always do when we're litigating a case is not only, of course, examine what this doctor's experience is, but we like to we try to humanize it. So like the question that you had, Michaela, about Kaiser, you know, one of the things we might talk about is a video, putting a video into the Department of Managed Healthcare, and trying to humanize what you're going through, because you know, people who don't, you don't know what's happening. Your doctors do know it. As a matter, as a society, when we think about all the time that's wasted between our doctors' offices having to fight with insurance companies, and insurance companies having hundreds of thousands of employees whose sole job it is to figure out how to not pay claims. It's just a whole waste of human resources. And, you know, I'd love to live to see the day when what your doctor asks for is what you get. And we don't have to fight about it or advocate for you, or you advocate for yourself while you're trying to go through a serious treatment. But that's where we are right now.
Lisa?
Yeah.
We do have a statement, just somebody kind of giving what is going on with them in the Q&A area, and a question.
Sure.
I can read it for you, or you
Oh,
want
I
to read
see it
out?
up here.
Yeah.
Can everybody see it, or should I read it? They did not.
Yeah. It's a good example. It's a great question.
Yeah, this first one is a really, really good example. So
I personally can't see it, so if you
Oh,
could read it,
okay.
that'd be great.
Okay.
Yeah,
why don't you?
me either.
Okay,
Okay.
I'll go ahead and read it out for
Go ahead.
everybody. A PCP sent somebody to a colonoscopy due to the person's age. They called their insurer, verified it was covered as preventative based on the age, and there would be no charge, and verified the provider was in network. So they're doing their due diligence, right, Lisa?
Yep.
Before the procedure, doctor said notes said that the patient had polyps, but they didn't, and they corrected the doctor. They did ask if there was a family history. They shared that the mother had them, but now they say they are. So I think we just want to confirm, is that when you say they are now saying it is not covered, if that's in the insurance?
Yeah,
I'm
it looks
thinking,
like
yeah,
it's the
yeah.
insurance company.
They appealed and it was declined. The person requested all the documents. They plan to appeal the third party doctor saying going to send me to collections. Ouch, that's never a fun letter to get.
Yeah.
And so the question is, how far does it go if your treating doctor has more clinical experience and expertise than the paid non-practicing reviewer?
Right. So yeah, this is a perfect question for us to talk about. So first of all, you said you've requested all the documents and you plan to appeal to the third party. So there's two different kinds of third parties. There's the external agencies that I was talking about, the Department of Managed Healthcare and the Department of Insurance. But some insurance policies also say, oh, we will send this to a third-party independent reviewer. I don't believe that those third-party independent reviewers are actually independent. And I often recommend that you don't do that, that you go straight to the state agencies, if your policy allows that. If you've already appealed once, my guess is this third-party reviewer is something like Maximus, or there's other companies like that the insurance company is going to hire and pay. And because the insurance company hires and pays it, you hardly ever get a reversal from them. So the first thing I would say, and if you want to talk to me after this, I'll look through it for you, is if you don't have to do that appeal, don't do it. Because you'll just get some doctor ruling against you who may have the credentials, who may say, I'm a gastroenterologist, who probably has never done a colonoscopy, but it's something that just hurts your case if you want to eventually be able to get the money back. I'm also really surprised your doctor is going to send you to collections, because usually I find, and especially when, if you would allow me to get involved, when I call the doctor's office and I say, hey, look, you got pre-authorization, you verified in network. I'm not even sure how they can charge you, because if they're in network, they can't balance bill you. So I would sort of have a conversation with them and say, look, this can't be the first patient that this happened to. Let us try to, set them straight and lay off a little bit. How far does it go if your treating doctor has more clinical experience? Not far enough, in my view. It should be the end of the story. But it's not. It always surprises me when it's not. When I have a patient with a doctor who, is a clinician, does this all the time, and then I have a reviewer who may have the right board certification or, letters after his or her name, but has no experience. Unfortunately, a lot of times, even the judges will say, well, I can't say that what they said was wrong, because they're a doctor too. We have ways of beefing up files and helping expose the non-practicing reviewer, but it's really difficult until you get to court. And who wants to go to court over an unpaid colonoscopy? That's why I try to see if I can massage it beforehand. So I'm happy to talk to you and see what I can do to try to help. But I'm most concerned that your doctor is sending you to collections, because as an in-network provider with a pre-authorization, I might argue with them that they can't bill you. At least I'd give it a try. Okay. Were there other questions?
There is another question from Sharon Miller. It's about the drug company change, how it pays for the portion of the drug. Okay, you got the gist.
I don't see it. Where is it under the questions or the chat?
It's under the Q&A. And so basically she was given a debit card by the health insurance company. And she's like, I wonder if I hope this is going to cover everything, but she's not sure. So are you familiar with insurance companies doing this debit card for payment?
No, and that's really interesting. And I wonder if that's part of this program. I've never heard of an insurance company giving someone a debit card. I'd love to take a look if you can scan it and send it to me. I want to make sure that they're not saying, because we gave you this debit card, it doesn't count you towards your deductible, because it's like they're giving you nothing. You're still going to have to pay the same amount in a deductible eventually. Now, again, if you have a year where you don't meet your deductible, then that's great. But none of us know what the year is going to look like. And so you don't want to end up at the back end being told, well, we gave you a $500 gift card, but, now you've got to pay that $500 back, especially, when you're looking at a catastrophic event. So I'd love to look at it if you can scan it and send it. Let's see. Double billed and then the insurance company. Yeah, those cards. I'm reading here another comment that you have one of those too, and you get double billed. The doctor makes you pay and the insurance company deducts it from the card. Yeah, that is nuts. And I think this is part of that same problem. It is so difficult to keep track of what goes on with your insurance. I mean, I can't even do it. And this is what I do for a living. I go on my portal. I try to follow, where the deductible's going and what they've charged me for things. I mean, I can't even imagine how hard it is when you're dealing with us and you don't litigate health insurance cases every single day. So happy to look at copies of the cards and anything you can show me about double billing. Because that just should not be happening. And at the very minimum, maybe I can help, because I've worked on this before, get in front of the California legislature and get some clarity in a new law to stop this madness, because it really is crazy.
Those are some really good questions.
Yeah.
I want to apologize if people heard my little dog barking in the background. She's just a T-Rex when the gardener gets here. We're kind of getting close to the time that it comes to an end, and I hate to disrupt the flow. It's just always the way it happens, right, Lisa? It's all of a sudden at the end, all these great questions come in.
Yeah.
But if you guys come back again another month, you know, even if it's 2 months down the road, you know, please just know that you can start right off the bat. You can email me the questions in advance. I put Lisa's email in the chat and mine. Don't worry, everybody's going to get an email when we're all done here. So you'll have mine and Lisa, you'll be CC'd on the email thread when I send it out. And we really appreciate you taking time out of your day to hop onto this webinar with Lisa Kantor and myself here at Kantor and Kantor Law. We care, we're people helping people. And obviously you could tell Lisa, she just knows how to do what she does so well, and she goes above and beyond. And a lot of times people think attorneys are just in it for, you know, the big win. And yes, that's important. And it's great. And case results are wonderful to talk about, but it's all about you guys. And that's the big win for us, is it's getting the max payout that you guys deserve to have, but it's getting the benefits covered. And it's that satisfaction that you know, our attorneys can put their heads on their pillows at night and know that justice was well served. So
thank you, Julie. And also I want to tell you, you have my email address. If you want to either email me the information, or you want to set up a call or a Zoom call or a consultation, I'm happy to do that for anybody. And we can go through your documents, and I can give you some advice and see if I can help you through the process. So don't be shy. I do love doing this. You know, as Julie said, it feels good to help people, and I feel like we all need to gather together so we can get more educated and we can help each other, because it affects all of us. So thank you for being here. Unless there's another question, I think we're going to sign off. Right, Julie?
yeah, I think we're good to go. Look
All
forward to everybody's feedback on that email. Everybody take care.
Thanks, everyone. Bye-bye.